Hello, everyone. My name is Christy Amobi. Welcome to our clinical education webcast. I'm delighted today to welcome Dr. John Binhlam of Advanced Skin and Laser Center and Binhlam Aesthetics. Dermatologists are frequently leading the way in the diagnosis and management of non-melanoma skin cancer. While Mohs surgery is the standard of care in the treatment of NMSC, the final decision on the treatment for patients should be based on their health, age, medical conditions, work, and lifestyles. Both the NCCN and the American Academy of Dermatology provide guidelines for the use of radiation as a treatment alternative for NMSC when surgery is not an option. In today's session, Dr. Binhlam, a Mohs surgeon with board certification in micrographic dermatological surgery, will provide more background about his decision to expand his practice with both superficial radiation therapy and electronic brachytherapy, and review how these modalities have benefited his patients, highlighting a few case studies. Thanks again for your attention, and with that, I'll hand it over to Dr. Binhlam.
Good evening, everyone. This is Dr. John Binhlam speaking this evening. I want to take a moment to express my gratitude to Christy and Extrol for allowing me to present the presentation regarding patient-centric treatment options for non-melanoma skin cancer with radiation therapy. I know everyone's had a very long day, so I will try to keep the presentation concise and move the talk along. So if everyone's ready, let's get started. To give everyone an idea of who I am a board certified dermatologist as well as a Mohs surgeon, and I've also been board certified in internal medicine. My practice is one that's strictly clinical, and I've been in private practice since 1996 in the Middle Tennessee area. The scope of our discussion this evening will involve the following items. I'd like to briefly discuss the current burden of non-melanoma skin cancer, the existing treatment options that many of you are already familiar with. I'd like to take a look at the perspective of the physician and the patient with regards to priorities. We want to review briefly the basic physics of radiation. Then I'd like to share with people what I see as being the difference between superficial radiation therapy versus electron beam radiation. I'd like to share some examples of cases that I have taken care of in my own office. And then I'd like to share with you some of the treatment pearls that I've learned over time that may help you as you treat people with superficial radiation. With regards to the burden of disease, as all of you are well aware, basal cell carcinoma and squamous cell carcinoma are the two most common skin cancers that we deal with, and they're considered to be non-melanoma skin cancer. And the graph to the right shows that we have approximately 3.6 million cases of basal cell carcinoma in the United States. Rarely do people die from basal cell carcinoma, and the cost of treatment can vary greatly upon the type and extent of treatment that is done. With regards to squamous cell carcinoma, we have approximately 1.8 million cases in the US per year, and the death per year, this is more significant because approximately 10,000 individuals each year die from complications of squamous cell carcinoma. Also, the cost of treatment can vary greatly depending upon the type and extent of treatment that's needed. Now, many of you are very skilled in taking care of the skin as well as taking care of skin cancer. So some of these things are not things that you are unfamiliar with. So I'll quickly go through what has been some of the more standard treatment options for basal cell carcinoma and squamous cell carcinoma. There is curettage and electrodesiccation. There is excision with margins. There's Mohs micrographic surgery. There's radiation. And then for select cases, there are alternative methods of treatment that include cryosurgery, lasers that include types of lasers such as pulse dye laser, CO2, and long pulse 1064. There's photodynamic therapy, the use of topical 5-fluorouracil, topical imiquimod. There are hedgehog inhibitor drugs for advanced basal cell carcinoma. And there's also now immunotherapy for advanced basal cell and squamous cell carcinoma. When I see a patient with a diagnosis of either basal cell or squamous cell carcinoma, like you, these are the priorities that I look at when it comes to considering treatment options for that patient. I like to look at the pathology report and look at the tumor characteristics, such as the histology, the clinical size, the anatomic location of the tumor. I like to look at the person's medical status and the comorbid conditions. And I like to know the skin cancer history. All these things are important, and I'll give some examples. Sometimes if someone has a very extensive history of multiple skin cancers and they have surgery fatigue, then it's something that I talk with the patients very carefully about consideration of other treatment alternatives that can give them a very reasonable success rate for clearance of the tumor while give them a break from surgery. However, the patient's priority regarding treatment is something that is a little bit more different than the physician's. They certainly want something that is highly effective. They don't want to have to worry about the tumor coming back. They are very concerned about the complications of the treatment. And if it's surgery, it could be bleeding, it could be infection. It can also be things such as how long does it take to recover from the surgery? For example, if they have a significant Mohs surgery of the pretibial area of the legs, then how about the pain, the discomfort? What would they be able to do following surgery? So there can be limitations in activity. Side effects such as loss of form of function, because if surgery is done on the face, especially around the nose, the eyes, sometimes it leads to functional and cosmetic deformity that people are very concerned about. There can also be long-term changes in skin pigmentation and numbness. Certainly if it is a person who is in the public eye, then they also are very concerned about scarring. And impact on daily activities are also top of mind for them as well. What I find is that while cost is very important to consider, sometimes that is not at the top of what patients consider to be important to them. So this does involve talking with the patients to know what are their priorities regarding treatment. Now, as far as the effectiveness of treatment for basal cell and squamous cell carcinoma, these are some of the numbers that you will find from various literature that we've had over the years. Electrodesiccation and curettage seems to have a very reasonable overall clearance rate, and the 5-year recurrence rate is also reasonable at 5 to 10%. It is a straightforward procedure, as many of you know, and I still perform this procedure quite a bit on many non-melanoma skin cancer. Surgical excision also can have a very good clearance rate, and the 5-year recurrence rate has been reported in the literature to be less than 5%. Certainly, I think we can all agree that Mohs micrographic surgery is the most effective treatment, with a clearance rate is between 98 to 100% success rate, and the 5-year recurrence rate should be less than 1% when done appropriately. For other methods of treatment, as you can see here on this slide, between cryosurgery, radiotherapy, imiquimod, fluorouracil, the clearance rate can drop off to some degree. However, for radiotherapy or radiation treatment, the clearance rate can still be also very reasonable with a 5-year recurrence rate that is higher than Mohs, but for appropriate patients, it would also be very acceptable. Then as you go to laser therapy, photodynamic therapy, use of hedgehog inhibitors, the clearance rate does drop off to some degree. Now, let's take a deeper dive into superficial radiation therapy for non-melanoma skin cancer. And I want to stress again that the gold standard for non-melanoma skin cancer is Mohs micrographic surgery with the application of Mohs appropriate use criteria, so that we're not doing Mohs surgery on everything. That would not be considered appropriate. Now, I'd like to share with you my journey towards bringing superficial radiation therapy into my practice. And it was an 8-year journey. It started back in 2012. And this was when I was aware of the original census device that came out for superficial radiation therapy. And over the years, I've talked with multiple companies, and these were the questions that I always had in my mind. Which of my patients would benefit the most if they had non-melanoma skin cancer? Do I have enough patients to justify the cost of bringing in that technology and training the staff and making adaptations in the office space for lead shielding of a room and the like? Would it cannibalize my Mohs surgery practice because I have an active Mohs surgery practice? And my concern was that if I brought in another technology, then I may lose some of my business for Mohs micrographic surgery. I can tell you that the answer to that is that it has not happened at all. If anything, it has expanded my reach to the community in terms of more patients coming in, because they were aware that I offered an alternative to surgery. I'm also worried about, would I be operating outside my scope of practice and be an outlier in the medical community? Because we do practice with other specialists such as medical oncologists, surgical oncologists, radiation oncologists, and how would they look at my practice saying, well, why is the dermatologist offering this? And to be honest, that was something that over time, as I spoke with my colleagues in the oncology field, they realized that the number of skin cancer cases that are out there that need to be taken care of is far more than what they can handle. So they have been very reasonable and have understood why I would offer superficial radiation therapy. At the same time, there are still cases in which I take full advantage of the fact that I have colleagues who can help me when there are more advanced tumors or tumors that are beyond the capability of what I feel my technology can handle for the patient. I also consider how difficult is it to ramp up my education on superficial radiation, because although I learned it in my residency, that was back in the early 90s, and it is now in the 2000s, and I'm starting to think, wow, that's been a while since I've had education on radiation therapy. Also, the staff were also concerned. Oh, wow, he's bringing in radiation. Are we going to turn green from the radiation exposure? Is it going to be safe for them? So those were things that we had to work through. I also thought about, well, what would it do to my malpractice premiums? I'm glad to say that after talking with my own state malpractice insurance carrier, it did not change my premiums at all. It may be different for you out there, depending upon the state and the carrier that you have. And then how do I navigate the complexities of setup, meeting state regulations for radiation, learning correct coding and documentation, and how do I decide on which superficial radiation system and company to partner with? Because my practice involves the use of many energy devices for cosmesis, I've been well aware of how important it is to have a good partnership with a company that provides service after the sale that will help you navigate a lot of the complexities of onboarding a device such as superficial radiation, but also how willing are they to help you when there's any kind of problem. Now, I'm glad to say that after 8 years, I finally pulled the trigger back in 2020, and I brought in the Radiant device from Xtrol. I will bypass talking about all the nuances of why I did so, but I will now move over to talking about understanding radiation, since many of you may or may not be comfortable with the concept that you'll be providing radiation treatment in your office. So simply put, radiation is energy. It comes from a source and it travels through space at the speed of light. It has an associated electric field and magnetic field with wave-like properties. And another name for radiation is electromagnetic waves. Superficial radiation itself is the delivery of radiation using X-rays, which are photons. And many of us are already familiar with dealing with energy devices that are in the ultraviolet wave spectrum, visible wave spectrum, even radio wave spectrum. So I don't think it'll be a big push for you to also learn this type of electromagnetic energy device. This chart here, what it shows is that if you're looking at the 7 different types of radiation waves, you will see that ultraviolet waves, okay, so that's ultraviolet waves, which are the waves that we think of in the spectrum of UVB and UVA, okay, it's right next to X-ray waves. Visible light, or visible waves, is just one below that. The key thing to get from this table is that with the X-ray waves, there is much higher energy than visible and ultraviolet waves. The wavelength is actually getting smaller and smaller, but the frequency of those wavelengths is much higher as you march across this table. The next slide puts it more in a graphical form where you can see that visible light, you have a lower frequency of amplitude. As you get into ultraviolet light, then it starts to be more closely packed together, and X-rays even more so. So basically, as you're going from visible to ultraviolet to X-ray, you're going to higher energy with actually shorter wavelength and higher frequency. Now, as it relates to what's the difference between superficial radiation therapy and electron beam radiation, electron beam can be considered to be very effective for both superficial and deep non-melanoma skin cancer, and it can be delivered with a high level of precision to various sized tumors. I usually tell patients that electron beam radiation is what's delivered at large hospitals and cancer centers because the electron beams are meant to go deep into body cavities. Therein lies some of the disadvantages of electron beam radiation when it comes to treating superficial skin cancer. The energy is so powerful that typically the radiation oncologists have to deliver the fractions of radiation into many more treatment sessions. A lot of patients that I've referred to radiation oncologists over time usually have to get 28 to 30 sessions on average. Some are even more than that. There can also be more noticeable side effects such as skin redness, itching, blistering, and also the size of the equipment is such that it is very hard to consider putting one in a physician office, and there is a big cost to it. The next picture that I'm going to show here is one such device that I did look at, which was meant to be a in-office device for electron beam radiation. And this picture to the right here shows an image of a table with an adult laying on it, and you can see the relative size of the machine relative to the individual and the table. So it does take up a lot of room, and it does cost a lot more. When it comes to superficial radiation therapy, the advantage of it is that it's low energy X-ray to the surface of the skin. So it does allow for high dose delivery to the target of the skin surface. It's very well tolerated with very low risk of side effects compared with other types of radiation therapy. The patients that I've treated, there is no heat, there's no pain with each delivery of a fraction of radiation. The footprint of the machine is also something that tends to be smaller, so it's more practical for a physician office. And there is also a significantly lower cost of acquisition relative to electron beam radiation. Now, it also has some disadvantages. The disadvantages so far that I've seen is that it really is only effective for superficial or thin non-melanoma skin cancer that are not advanced tumors. At the same time, I would say that probably over 90% of the cases that we see in a dermatology private office is that we are not seeing the advanced tumors. Typically, those cases are going to cancer centers because they need a lot more also intensive surgery, radiation potentially, as well as systemic chemotherapy or immunotherapy. Also, the limitation is related to the size of the tumors that can be treated. Like with the Radiant device, the largest size of applicator that I can use to treat a patient is a 4 centimeter applicator, and that does include the margins around the tumor. All right, and then let's talk a little bit more about the device that I have, because that's what I'm most familiar with, since that's the device I opted to go with and use in my practice. So it is superficial radiation, low energy using photons, and the penetration into the patient's skin is usually a maximum of about 5 millimeters. However, that is more than adequate for the vast majority of basal cell and squamous cell carcinomas that we treat. When we use the cone and protect the surrounding skin, you are protecting the surrounding tissue so you don't get collateral damage to surrounding tissue. It is a very good option for patients who cannot or do not want to undergo surgery. It's also a good treatment option where surgery and reconstruction are difficult, such as the nose, the scalp, the hands, or the pretibial area. With the Radiant device, there are two types of surface X-ray therapies that are available. The superficial radiation therapy, which is 80 kilowatt, and the electronic brachytherapy, which is at 70 kilowatt. And the vast majority of my patients receive the superficial radiation treatment as opposed to the electronic brachytherapy, and it just has to do with the Medicare coverage by my MAC, which is Palmetto GBA, that does not cover for EBT, although we're trying to get them to change their policy on that. There are other Medicare carriers that do allow for EBT, so you will want to check with your local Medicare carrier to see what they do allow. Now, most patients that meet the NCCN guidelines are eligible for getting superficial radiation. And as I said previously, the tumor size amenable to treatment is typically up to 4 centimeters with the size applicators that I do have. I believe you can get some larger ones, but to be honest, if it starts to be bigger than 4 centimeters, it probably would not work well anyway with superficial radiation in general. Now, the patient's functional status and preference to avoid surgeries are important factors to consider superficial radiation. It is also unlikely to cause scarring, and typically it results in little cosmetic changes to the skin. I'll show you a couple of pictures of how some of my patients have looked after treatment in a bit. The treatment times invariably are short. For SRT, it's typically less than a minute and it's painless. If you do EBT, electronic brachytherapy, then it does take more than a minute and can take several minutes, still a very short period of time. Healing time at the site of radiation therapy usually occurs in 2 to 6 weeks after the end of a treatment course. And the healing is where the skin is no longer red or have any desquamation or peeling. Side effects are generally mild during treatment, such as some itching, some sensitivity, and they tend to go away quickly. Now, certainly with like with anything, there are contraindications to consider when it comes to offering superficial radiation. Sites of previous burn may not do well. Sites of prior radiotherapy or radiation may not do well. People have very fragile tissue paper type skin, whether it be from steroid use or just age, may not do well with that. If people have vascular insufficiency, for example, if you're treating a digit, a hand, or a lower extremity, that may be an issue to consider. The middle third of the upper eyelid, patients with genetic syndromes such as Gorlin syndrome, ataxia telangiectasia, xeroderma pigmentosa, radiation in general is contraindicated, as that will accelerate their development of more skin cancer. Large lesions that may involve cartilage, bone, and joints will be a contraindication. As we have said before, typically with superficial radiation, it is not meant for tumors that extend below 5 millimeters beneath the skin surface. Skin overlying the shin and malleoli of the lower legs may have some issues with impaired healing. And a relative contraindication is treating people who are younger than 50 years because of the theoretical concern for future carcinogenesis at the surrounding site of treatment, or worsening of the cosmetic outcome over time in terms of getting skin atrophy and telangiectasia and skin color changes. Okay. With the SRT device that I have, as I said before, I do primarily use SRT. The source to skin distance is 6 centimeter. It is 80 kilovolt, and that is more than sufficient energy to treat most non-melanoma skin cancer. And the standard applicator sizes, as shown in the picture on the right, the ones that I have range between 1.5 to 4 centimeter. I did not get the one with only 1 centimeter because usually if a tumor is that small, I'm not going to be using superficial radiation for it. And typically the treatment course for a patient is usually 2 to 3 fractions per week with 1 day of rest in between to allow them to recover from the effects of acute radiation. With EBT, it's very similar. The source is the same. It's just that the applicator are shorter in distance between the source of the radiation to the skin. It's 5 centimeter. It doesn't have to have as much energy delivered. The word brachytherapy comes from the Greek word brachys, which means short. So it's a short distance from the source of the skin, which allows you to give a higher dose of radiation to the surface of the skin with more rapid fall off of radiation away from the treatment area. So it does really reduce the exposure of surrounding tissue to radiation. And again, it's still the same size that you can get between 1 to 4 centimeter. In my practice, I keep the 1.5 to 4 centimeter range. And if you're wondering, because I didn't put it in here, the other sizes that they commonly have are going to be, it's the 1.5 centimeter, the 2, the 3, and the 4 centimeter. Okay. And with electronic brachytherapy, one of the advantages of that is that because you don't have to give as high of a total dose of radiation, then the total number of fractions that are needed are also lower, so that you can treat in 10 fractions or less and still end up with a very good success rate in clearance of the tumor and also a good cosmetic outcome. Now, I'm going to show a couple of examples of patients that I have treated. This is someone who had a basal cell carcinoma, and that was, I outlined the area prior to me doing a biopsy. And she had had multiple skin cancers in the past. She did not want to have more surgery. And as you can see from that size, the width of it, if you were to do surgical excision or Mohs micrographic surgery, reconstruction would be very difficult to pull her skin together because she has taut skin, and the scar would be very obvious in the center of her forehead. The picture on the right, I know it's a little bit different lighting. However, hopefully you can appreciate she has had minimal changes in that side. And this picture was taken about a year after she completed therapy. If you look very closely with the magnifier, then you would see that there are some increased small telangiectasia, and the skin there is smoother than the surrounding skin. The patient was very thrilled to have successful clearing of the tumor without having to have surgery. Another example is someone here who actually had multiple biopsies done in the scalp. The one that's lettered B turned out to be a invasive squamous cell carcinoma. A and C was actually, they were hypertrophic actinic keratoses. This was a follow-up many months later, and the only reason why I marked A and B was that there were some suspicious lesions outside the field of therapy that we did biopsy to make sure they were not cancer, and fortunately for the patient, they were both actinic keratoses. But what you can clearly see here on this treatment is that he does have some hair loss, which is a factor to consider if you're going to talk with patients about using superficial radiation in a hair-bearing area. This gentleman was actually in his 80s. He lived in a skilled nursing facility. He actually was very functional, and he really wanted to avoid surgery because you can imagine the surgery for a lesion of the size outlined by letter B and the image on your left would have left a very large surgical defect, and closure would have been extremely difficult, if not impossible, and healing by second intent would have also been very prolonged for this gentleman. So he was very happy. One comment I'll make about his case too is that we were treating him during the pandemic, and his skilled nursing facility put all of the residents on lockdown, where each of the residents were not allowed to leave their room to even eat with other members of that skilled nursing facility. And he joked about the fact that because he had the skin cancer that needed a series of radiation treatment, it was his get out of jail card to be able to leave the facility and come out and interact with people again. So I thought that was kind of a cute story. And then this is one other example that I give. The picture on the left actually has two markings of where we had done biopsies. Both of those things turned out to be invasive squamous cell carcinoma. And as you can see, he has tremendous pitting edema of the lower extremity. And in the past, he's also had multiple skin cancers remove me from his leg, and with surgical removal via Mohs surgery, it was very difficult to close things. Many times we had to use secondary intent healing, which also took a very long time because of the pitting edema that he had. However, this picture that was taken, which is about 8 months later, the area still has some increased redness on his left medial pretibial area. The other area you can't really see, the Band-Aid that you see above is actually at a site where he has some trauma, so he covered it up. It was not covering up the second site of radiation treatment. So here's another example of where offering people the option of superficial radiation is very reasonable. And as you can tell, the examples that I showed here, all the patients were more elderly. All of them were over 70 years old. Now, what have I learned since incorporating superficial radiation therapy in my practice over the last 2.5 years is the following. I know that with treatment of patients using superficial radiation, certainly I can turn over a lot of the treatment to qualified individuals such as radiation therapists. However, I think that even if you do have someone that you trust to do the treatment, physician involvement is very key. You learn more when you have hands-on involvement in the care of the patient. Always pay close attention to proper and adequate shielding at each treatment session, because while we want to have effective treatment, we also want to do it in a very safe manner, not only for the patient, but also for your staff. Always make sure that you have good contact with the applicator base to the treatment skin to avoid gaps. When I do it, I'm always trying to be at eye level with the area where the applicator is placed at the site of treatment to make sure that I see no gaps at all with the skin. As part of the treatment protocol, you do have to create a template that you will use to ensure that you always mark the same site of treatment every time that you treat. And I would suggest that use the templates to always guide you in terms of where you need to mark the cone to be placed. Because even though you may start to see radiation dermatitis and you may see a circle of redness, it's not always a distinct edge to the redness. So the borders that are indistinct do not allow you to consistently center the applicator at the same site at each treatment. So use the templates to always guide you at each treatment. I found that to be very helpful. And then when you're doing the planning, I find that using a very good magnifier allows me to see the surface clinical margins much better, so that I can accurately mark where I feel the clinical margin should be. And then from there, I can add the additional margins of 4 to 5 centimeters, millimeters typically, around there in order to make sure that we have adequate margins similar to a surgical excision. I have found over time that I adjust the margins based upon clinical judgment, along with looking at the pathology report. What I mean by that is that while the standard recommended margins around the site of the treatment is typically about 4 to 5 centimeters, if clinically the lesion prior to the biopsy was something that was larger, let's say that it may be about 2 to 2.5 centimeter in diameter, I may opt to go with wider surgical margins of like 6 millimeters to make sure that it's similar to when I excise a squamous cell carcinoma that is larger. Usually larger skin cancers require larger margins to ensure you have adequate clearance. And sometimes I will bring the margins down to even around 3 millimeters around the site, keeping in mind that similar to when we do Mohs surgery, when we remove the tumor and we take margins around there, initially we're only taking about 2 to 3 millimeters anyway, and many of the times those things will be clear. So in an area where you really need to try to spare treating too much of the surrounding skin, then I do go a smaller margin. Also, when designing the template, use multiple reliable anatomic landmarks, such as a mole, such as a seborrheic keratosis, such as a scar. I've also found that using a device like the one I'm showing here is also very beneficial if I can see the blood vessels, the veins around that area, because I will mark it on my template, and that gives me another anatomic reference point to make sure that each treatment session I am applying the template correctly over the site where I want to deliver the radiation. And as far as radiation dermatitis, the side effects of the SRT treatments that I've done so far, in general, what I generally have seen is that people tend to get mild to moderate erythema and some peeling skin and some itching. And when I start to hear that people noticing a little bit itching or tenderness, I have found that the use of just regular over-the-counter hydrocortisone ointment has been very effective to actually alleviate the symptoms promptly. They don't have to use it all the time. And it tends to settle down some of the radiation dermatitis so that people can continue with treatment. There is not any good data to say that that is whether there's any chance that it may be harmful to the treatment outcome. So right now, I'm continuing to use a little bit of over-the-counter hydrocortisone. Also, frequent use of bland moisturizers on the non-treatment days and making sure that people use gentle soaps lessens the chance that the radiation dermatitis will progress or get worse over the treatment sessions that the patient will have. And I always encourage people to use a physical sunblock with a minimum of SPF 30 on all the non-treatment days, as well as after the treatment session has ended. So those are the things that I've kind of learned over time. I'm sure that I'll learn more over time. For those of you who are already doing superficial radiation, probably you have far more tips than I have written here. I hope this presentation has been helpful if you are investigating the option of bringing in superficial radiation therapy for your skin cancer patients. Thank you for your time this evening, and now we'll open it up for questions. Thank you.
Thank you, Dr. Binhlam. I appreciate that thoughtful presentation. Can you hear me okay?
Yes, I can. Are you able? Yes.
Yes, I hear you great. Just as a reminder to the attendees, if you have any questions at all, you can go ahead and submit them using the GoToWebinar control panel in the questions tab. Dr. Binhlam, we do have a few questions coming in. Just to kick off the Q&A, does commercial insurance cover SRT and EBT? And in particular, there are some questions specifically around HMOs and how have you seen the coverage with regard to HMOs?
Yeah, so let me qualify my answer by saying that I have a small practice, and currently I only participate with traditional Medicare insurance and with Blue Cross Blue Shield of Tennessee. Outside of that, people see me as direct pay patients. What I found is that with traditional Medicare, and my Medicare carrier is actually Palmetto GBA, they do not require that we do any type of insurance pre-authorization for superficial radiation therapy for non-melanoma skin cancer. With Blue Cross Blue Shield, we do have to do a pre-authorization process. It takes some time for our staff, but it has not been overly onerous. And we've never been denied on coverage for that when we requested that in advance. We also have seen that there have been some cases where patients have seen us out of network, like for example with Humana insurance, and we have been able to talk with the company and have them agree that if we continue to see the patients and provide radiation therapy, they are willing to pay us at the in-network rate, even though we're actually out of network. And if it's reasonable, I accept it. So we've been able to do that. Hope that answers that question.
Yes, thank you. Next question, what is your dose fractionation regime for BCC and SCC?
Yeah, so the dose fractionation that I like the best when it comes to superficial radiation therapy has been for both roughly about 16, 17 sessions. I try to go for a total dose of about 51 centigrade. So that's what it gets broken down to. If I do EBT, I do cut down the total cumulative dose to about 4,800 centigrade. And I usually get it done usually in about 10 sessions. As I've said, EBT is not necessarily covered by insurance, especially in my area, Palmetto GBA. It's not covered, but I look at delivering this service as something for my patients for the benefit of them. So if we feel that we need to go with EBT because of the patient's personal issues, such as they live far away and they need to get done in fewer sessions, or they actually need to leave town where they have a shortened time frame in order to do treatment. I've done EBT for those people, and I actually do it actually free. I do not charge them for that.
Okay, thank you. Yeah, that was the next question around the patient's consideration for the total number of treatment sessions, and it sounds like you definitely adapt your care plan to that particular situation, and obviously, like the insurance coverages vary, widely depending on the state that you're practicing in.
Right. If I can make another comment also, Christy, is that I arrived at that that total number of fractions and of about 16, 17 sessions for a total cumulative dose of 5,100 centigrade, just a little bit over time and based upon data that's been put out there on the use of superficial radiation. And it seems to work well for my patients in terms of them having a very limited amount of radiation dermatitis of any type of skin breakdown. So it's made me feel very comfortable with that regimen. I think one of the more common questions that comes up from patients is going to be, gosh, is it really needing to be that many sessions? And I do remind them that in comparison to electron beam radiation for the same skin cancer, my colleagues in radiation oncology here in Middle Tennessee, it's usually about 30 sessions. So it's actually less than what will be required at a cancer center. But also, I stress that the reason why we break it up into a series of sessions like that is so that we can protect their skin from breakdown, because if they get ulcerations, they're very hard to heal. And we want to avoid non-healing ulcers in the area of radiation treatment. And a secondary benefit is that so far since 2020, when I brought on the Radiant device, and I've seen people back for follow-up, albeit now, only about 2 years since they got treatment, the cosmetic result actually has been very good. There's been minimal skin color changes in terms of lightening of the skin, any type of telangiectasias or redness, or any type of significant skin atrophy.
Okay, thank you. Yeah, you did mention the side effects with the erythema, and possibly the consideration of ulcers. Are there any other side effects that your patients have experienced?
So we've had, along with some of the erythema, some itching, some burning, stinging, a little bit of skin tenderness, but we've been able to get past that pretty much, for the most part, by judiciously using a little bit of over-the-counter hydrocortisone. There have been some times in which if there's moderate amount of redness with peeling skin and I start to see the skin wanting to crack, we do take a limited break from treatment where I may pause the treatment for about 1 to 2 weeks and resume the treatment again. I do check with the radiation physicist that I work with just to recalibrate what we should deliver as the remaining doses to make sure we should still get a effective clearance rate of the tumor.
Okay, thank you. Next question. Have you seen any issues with using the superficial radiation therapy for NMSC if the patient has psoriasis?
Actually, I've had several patients who have either atopic eczema or psoriasis. I have not seen that to be an issue. So.
Okay, great. Next question, do you use any shields for tumors near the eye, the eyeballs?
I do. So actually, we have treated in particular one person where the right lower eyelid squamous cell carcinoma need to have actually a corneal shield, and we actually have used that. And again, there's special tungsten shields, and they have to be a certain thickness to be put over the eyeball itself. And so we've gotten very used to numbing up the eyeball, inserting it, taking it back out. Patient had no ocular side effects during the course of treatment or afterwards. So he was very pleased, and it was something that I feel very comfortable with too, because with the use of other energy devices like lasers around the eye with resurfacing around the eye, I also feel very comfortable with putting on corneal shields for those procedures too.
Okay, thank you. Next question, can you treat multiple lesions at a time or only one at a time?
You can certainly treat more than one, and actually I didn't mention this in the talk as being a potential benefit for patients, but for my practice anyway, what I do is that if people have 2 or 3 non-melanoma skin cancers, such as basal cell or squamous cell or the combination, I will treat all 3 at the same visit. I actually don't charge more for that in terms of the number of units used for the radiation treatment. And so I recognize that that is a financial hit that I take, but it's for the benefit of the patient. So I don't mind doing that. It is a added benefit for the patients when they have multiple skin cancers.
Okay, thank you. We're coming up on our time. We have time for a couple more questions. What was your initial patient volume and how have you seen it change over time?
Yeah, so when I first started, like I said, I wasn't sure that I would have enough patient volume. And when I first started, it did involve us talking with patients and being upfront and saying, while I am a board certified dermatologist and I'm an expert in taking care of the skin, this is a newer technology that I'm bringing on to benefit patients. And I reassure the patients that we follow all the state regulations for delivery of radiation, and that we also work with a radiation physicist in the background to verify all of our numbers, and patients got a very good comfort level with it. Over time, patients that we've seen have become very comfortable with our office offering it, and we've actually had referrals from our patients of other friends or family who were looking for a non-surgical option to surgery. So we've gained patients that way, because sometimes someone that they've seen before said the only option you have is surgery, and once I evaluate the patient, if I think it's appropriate, I do offer it to them. They're very happy that we can give them a non-surgical option to surgery all the time. Now, patient volume. I think I got a little bit sidetracked there, so I apologize. So I asked my staff today just to check and see how many distinct cases have I done. As we started offering superficial radiation therapy since 2020, over time, our patient base got very comfortable with what we were delivering. They saw good results for themselves. So we've had new patients come to our practice because they were recommended to come see me since their other doctors did not offer them the alternative of superficial radiation therapy, and they had heard good things about it. And once I evaluate these new patients, if it's appropriate, and we deliver the radiation therapy, those people have also been very happy. So the word has started to kind of get around in the local community that I do offer it, and people can get excellent results from a non-surgical treatment of non-melanoma skin cancer. As far as total number of patients I've treated so far, I did ask my staff to see how many we've treated so far. So since 2020, when we brought it on, we now have treated 156 distinct patients. Some of these patients have been treated for several skin cancers at a time. Some of them have also had more than one skin cancer treated at different time intervals since 2020, because once they've had superficial radiation, they want to go back to that type of therapy because they like it, it works well, it does not disrupt their lifestyle, or does it affect their functional activities in terms of things that may be on the pretibial area, things on the scalp, or certainly things around the nose or eye. While I recognize that number may not be large, I think that it is a very helpful tool in the management of skin cancer, because even though Mohs surgery is considered the gold standard, there are patients in my practice, and certainly in the audience practice too, where surgery may not be the best option for the patient once you consider all of their concerns regarding the effects of surgery and their lifestyle.